And if there are any questions while we're going through this stuff, just please feel free to stop me and we can go through it. So as I'm sure all of you know, syphilis is caused by a bacterial infection with the spirochete treponema pallidum. It's a gram-negative bacteria. It's an interesting bacteria because it's highly sensitive to oxygen and temperature, and so it's extremely difficult to culture. And so early on, testing for syphilis was dependent on a dark field test. But now with the advent of genetic technology, it's almost primarily tested through PCR. It's passed horizontally from person to person through direct contact, usually sexual activity, and it's passed vertically from mother to baby, which results in congenital syphilis. This is an electron micrograph of the spirochete, and this is a specific staining that you can see that spirochete. It reminds me a lot of saffron, actually. And as I'm sure all of you are aware, over the last probably 5 to 8 years, the rates of syphilis in the community have increased dramatically. This is the most recent data that has been reported by the state of Texas. In the top red line, you can see these are maternal syphilis rates. And as you can see from 2012 to 2018, the syphilis cases in mothers during early pregnancy, so that's the first and early second trimester, have almost doubled in that time. And I can tell you, extrapolating out some of the national data from the CDC, the rates since 2017 have doubled again. And so that number somewhere between 800 and 1100, the number as of right now is likely double that. As you can see in the bottom blue line, which is congenital syphilis cases, it basically follows along with the maternal syphilis cases. And the rates that we're seeing of congenital syphilis is tracking along with maternal syphilis cases. So those rates in the 2017 to 2018 range of like 116 to 300 cases in Texas has almost doubled. I have more up-to-date data from the CDC that we'll go through. But as you can see, the last 5 years, the rates of syphilis in the community and rates of congenital syphilis have increased dramatically. This is a really interesting chart looking at syphilis rates nationally broken down by state. And as you can see, there are significant geographic differences. Although Texas is not the worst, it's obvious from the map that there tends to be higher rates of syphilis and congenital syphilis in the southern states. Texas is like 9 cases per 100,000. This data is a few years old, so the rates are going to be slightly higher now. But as you can see in kind of the surrounding southeastern section and New Mexico, Arizona, the rates are much higher. And then in some of the larger urban centers, New York, Illinois, Chicago specifically, the rates are higher. And we'll go through some of the risk factors that may explain some of this data. And this is an interesting slide that the CDC published looking at increases among all STDs since 2001. The reason why the CDC specifically put this out is because 2001, as all of you know, was COVID. And what they've seen since COVID ended was an increase in all STDs, including gonorrhea, syphilis, and congenital syphilis. There's been a 74% increase in maternal syphilis since 2017, and a 203% increase in the rates of congenital syphilis since 2017. So really interesting data. So this is about as up to date as the CDC has information. And from 1991 to 2005, syphilis rates actually decreased, but then starting in 2014, they began to increase again. And by 2014, they had risen to 11.6 per 100,000. By 18, they had almost tripled to 33 cases per 100,000 live births. And again, from 2018 to 2021, they have doubled. And I can tell you the rates of, as of like late 2023 data, early data that I've seen, the rate is closer, it's in the low 90s, 93 per 100,000 live births. So it appears to be increasing. Despite some public health initiatives to try to curb this increase, it just continues to rise. So there are quite a few risk factors that increase rates of congenital syphilis, including the rates in the community that the patients live in, multiple sexual partners, the presence of other STIs, in particular including HIV. HIV and syphilis are a particularly bad combination that leads to significant morbidity and mortality both in women and their offspring. Recent immigrants to the United States have higher rates of maternal and congenital syphilis, incarceration, transactional sex, unstable housing, and then limited access to prenatal care. Interestingly, the national data did show, however, that almost half of congenital syphilis cases lacked any of the traditional risk factors. Black women had 4.5 times higher odds of birthing a child with congenital syphilis. Rates are higher among Hispanic women, mothers in lower socioeconomic status, mothers who live in rural areas, immigrants, and the use of drugs, in particular, the use of cocaine increases the rates of syphilis by 9.3 times. So when we are looking at testing for congenital syphilis, the three factors that make it highly probable or confirm a case is an abnormal physical exam consistent with congenital syphilis, and I'll go through those exam findings, an RPR or a VDRL that's fourfold higher than mothers at delivery, and a positive dark field test, which is the older test, or what most people are using now, which is a PCR. So the common clinical findings of congenital syphilis include rhinitis or snuffles, hepatosplenomegaly, a desquamating skin rash, Hutchinson's triad, which is notched teeth, deafness, and interstitial keratitis, anemia, as well as meningitis. This is a nice graphics out of one of our pediatric textbooks that gives a comprehensive list of the clinical findings and clinical manifestations of both early and late congenital syphilis. I didn't provide it to go through in detail, but just for y'all's reference, I think it's handy to keep this around, especially when a case comes in, just to ensure that the appropriate screening's been done and we're looking for the right things on our initial physical exam. So this is a very old image that published for the last 20 or 30 years in several pediatric textbooks, and is highlighting the physical exam finding of snuffles, which is a highly infectious, purulent, serous, and hemorrhagic nasal drainage. This and this slide are both highlighting the desquamating skin rash typically found on the palms and soles of the feet. These two slides are looking at notched teeth, which is one piece of Hutchinson's triad. And the other finding that we often look for is Wimberger's sign, which is bilateral focal destruction of the medial aspect of the proximal tibial metaphysis. I don't know if you can see my pointer, but specifically the destruction in this area. So the next four slides, and kind of what I wanted to spend the most time on, was looking at the most commonly used algorithms and some of the reasons why we actually developed our own algorithm, just to help simplify this process. The simplification of our algorithm may lead to slight rates of over-treatment, but prevent missed cases of possible congenital syphilis. This specific algorithm is taken from UpToDate. It was last updated last year. While comprehensive, as you can see, it is quite cumbersome. This algorithm here is taken from Redbook from the American Academy of Pediatrics. This was last updated in 2018. It is the same even in the most up-to-date edition of the Redbook, which was last published in 2023. This algorithm remains unchanged. Again, it's quite a cumbersome algorithm. It is hard to follow, and I think led to confusion and missed cases of possible congenital syphilis. This is a simplified and very user-friendly algorithm that we were using prior to the development of our own algorithm. And it breaks it down into infant and maternal criteria. So specifically that we've already discussed the infant criteria. So clinical exam findings consistent with congenital syphilis is one of the infant criteria. The second is an infant titer greater than fourfold higher than mom's titer, and then a positive PCR. The maternal criteria to consider are the treatment or lack of treatment, inadequate treatment, non-documented treatment, treatment with a medication other than non-benzathine penicillin, and then treatment either greater than or less than 4 weeks before delivery. For treatment to be considered adequate, the mom needs to be treated greater than 28 days before she delivers. If it's 27 days or less, it is considered inadequate treatment, and the risk for transmission and development of congenital syphilis is high enough to warrant full evaluation and treatment. And the evaluation that we do here and is consistent with the AAP standard of care is a CSF analysis with a CSF VDRL, a cell count, and a protein, a CBC specifically looking for anemia and thrombocytopenia, long bone radiographs looking specifically for that Wimberger sign. And then we also here include an ocular evaluation for signs of ocular involvement in congenital syphilis. It requires a slit lamp, and so that may not necessarily be possible if ophthalmology isn't available at your center. If all of the infant and maternal criteria are met to suggest no suggestion of congenital syphilis and adequate maternal treatment, and the evaluation of the infant is normal, you can consider, and I would highly recommend, a single dose of benzathine penicillin. The other thing to remember is that if there is any concern for follow-up, the AAP does recommend to err on the side of caution and complete a full 10 days of therapy. Reason being is that some of the early testing can be a false negative. And so these children do need to be tested at a later stage, either by their PCP or by a pediatric infectious disease specialist. And so if there is any concern that this child may be lost to follow-up with any concerning maternal factors, full treatment is often warranted. And then in this slide, this is the current algorithm that has been developed for and being used by UMC and some of our outlying centers. So any mom who has a history of syphilis, even if treated, should have repeat testing at the time of delivery. As well, the infant should have testing done. Again, to highlight what complete maternal treatment is, it is treatment with a non-benzathine penicillin regimen. It's given in 3 doses, exactly 2 weeks apart. If the timing of those doses is abnormal, for instance, if a dose is given early or there's several weeks between the second and third dose, the treatment is considered inadequate. Again, just as a reminder, the last dose of the 3-dose regimen needs to be given at least 28 days before delivery. And the other thing that oftentimes gets us into trouble is that all 3 doses need to be well documented. If any of the 3 doses are not documented, if you get verbal report without documentation, we, at least here at UMC, consider that inadequate treatment. If all of those criteria are met and mom's treatment is considered adequate, we then send titers off for mom to ensure that her titers remain low. So stable and low titers is any titer of 1 to 4 or less, as well as mom's titers should drop by 4-fold or greater after treatment. If the titers rise above 1 to 4 or more, or there is not that decrease, there is a suggestion that mom has been reinfected, at which point the child would need a full evaluation and treatment. So no or incomplete maternal treatment is considered any other antibiotic, less than 3 doses if the doses were inappropriately timed, if any of them weren't documented appropriately, if there was less than 28 days since the last dose and delivery, or if the infant's titers are 4-fold higher than mother's post-treatment. So I did want to just take a minute to talk about fold change, because this is often confused and I have to look it up sometimes. So a 4-fold change is equivalent to a change in 2 dilutions. So basically what that means is that if a mom comes in and tests with titers at 1 to 16, to be adequate treatment, her titers need to be 1 to 4 or less to be considered 4-fold. Or another example would be if mom is 1 to 32, her titers need to be 1 to 8 or less to be considered adequate treatment. And the treatment course currently being used and recommended by the American Academy of Pediatrics is benzathine penicillin. It's 50,000 units. I have it on the next slide. 50,000 units per kilo per dose IV Q12 from day 0 to day 7. At day 7, the dosing changes to 50,000 units per kilo per dose Q8. And so what we end up doing here is for the 10 doses, for the 10 days, we end up counting specific doses to ensure that it is adequate. And so it's 14 days over the first 7 days, and then 9 doses over the course of the next 3. So it ends up being 23 total doses. And then just as a caveat and a reminder, if mom's treatment is considered adequate and her titers are low and remain low, you could consider, and I would highly recommend, a single dose of penicillin IM of 50,000 units per kilo. So that is the end of my slides. Thank you guys for listening. I wanted to primarily with this talk this morning highlight just the significant increase of congenital syphilis and maternal syphilis in the community over the last several years. Like I mentioned early, it was rare. We were treating a few cases a year early in my career, but now it is rare at any point that we don't have at least one child in the unit who's being treated for congenital syphilis. And I'm sure you guys are all seeing the same trends in your community as well. And then this algorithm is free to use by anybody that would like. If anybody has specific feedback on it, we would love to hear it. But it seems to be working well for us. It is simplified the evaluation and treatment to ensure that no cases are missed, with the added caveat that there may be a few cases of children that get treated for congenital syphilis that may not necessarily need it, but we have developed it with the idea to ensure that we don't miss any cases. So this is my amazing transport team and some of our nurses and our transport director, Dr. Tenpenny. They make our job possible and take amazing care of the patients here in our region. Any questions? I don't know if they can hear me or if I can hear them. What do I need to do?
Just go back to that last slide if you want to.
This one?
Could you just kind of recap and let everybody know if they're in the region in a rural facility, at what point they should transfer, and just some considerations in the pre-hospital setting, pre-neonatal ICU setting.
Okay, there was a question about when to transfer to us. So I think that if in some of our outlying centers, when they choose to transfer to us, my biggest and best advice would be if there is any concern for congenital syphilis based on physical exam findings, based on lab work, based on your long bone x-rays, or if an ocular evaluation is needed, we are happy to facilitate that. The other tricky thing about this is an IV only treatment. And so if there is any concern about maintenance of IVs for a 10-day period, that oftentimes can be a reason for transfer. We typically put in PICC lines in the first 24 to 48 hours of hospitalization once we have determined that the child needs a 10-day course of treatment for congenital syphilis. So we try to get the PICC line in early to prevent the child from needing repeat IV sticks, just to minimize pain and suffering as much as possible through the course of this, what is a long IV treatment course. And then, of course, if there are any questions, I oftentimes receive phone calls from outlying centers to discuss the specifics of either mom's treatment or baby's evaluation. We are happy to take those phone calls and go through the baby's history and findings and mom's history and determine if transfer is necessary. Oftentimes it is not. As well, if there is any concern about that follow-up piece, about getting the appropriate testing done, we can always help facilitate getting you guys, getting these babies seen by our pediatric infectious disease specialist here in Lubbock. So really, we are available for whatever questions or concerns or discussions or transfers that may be necessary. Are there any questions about our algorithm, about the evaluation, treatment, anything in general?
Hey guys, it's Kelsey. If anybody is interested in the algorithm or getting a copy of the slides, just let me know and I'm happy to share with you. Just send me an email or put a comment in the chat and I'm happy to share those slides or the algorithm with you. Again, please ask any questions that you have or any considerations. If you've run into any situations where you thought you needed some extra advice, please let us know. And if you don't have any questions, again, I'll put the link to the evaluation in the chat, and I will be distributing the CNE certificates in the coming days. Thank you guys for joining us this morning.
I have a quick question, if I could ask real quickly.
Of course.
This is, I'm curious about on the maternal side, is it very often, or have you ever encountered a mom who was allergic to penicillin? And if that's the case, then what are her treatment options?
That's a great question. I believe there are some alternative therapies. I'd have to get with our OB folks. The other thing that they're, at least in the current guidelines, both in the AAP and some of the regional centers, they're very specific about any treatment with a non-benzathine penicillin being considered inadequate treatment. But there, of course, are going to be moms who are allergic to penicillin. I've seen clindamycin used. The treatment course is different. They require multiple doses, and I think probably the more important piece of the testing is ensuring an appropriate fourfold decrease or more, and ensuring that the titers remain low. So I think if a non-penicillin antibiotic needs to be used because of a maternal allergy, the most important piece of that then becomes ensuring that her titers fall appropriately and remain low. If the titers fall and remain low, I would think that the treatment would be considered adequate. And likely the risk of congenital syphilis is low and the same as a mom who's being treated by with benzathine penicillin or non-benzathine penicillin. The interesting thing is the rates of transmission from mom to baby are highly dependent on the bacterial load, or what the textbooks refer to as spirochete anemia. And so once the amount of bacterial load has been decreased to a sufficient amount, the rates of vertical transmission shouldn't be any higher. So I think, and the titers falling should be suggestive of that bacterial load decreasing. So I don't see any reason, as long as those titers fall and remain low, that the risk of transmission would be any higher. So I think most of it would be dependent on those titers and the titer following and remaining low. So you may need more frequent testing of mom of those titers to be sure, but I know there are cases that that clindamycin has been used here in Lubbock.
And then
Dr. Sorrell, we do have a question in the chat, and it says, I do have a question. Should a RPR be drawn on every newborn or only if the mom is positive?
So if mom has any history of syphilis, so even if she was, say, treated 3 years ago in her pregnancy and her titers have remained low, mom would need repeat testing and baby would need testing. If mom has never had a positive test for syphilis, then the child does not need any testing for syphilis. I would also argue that testing of babies whose moms have any history of drug abuse or have a history of other STDs should be considered, because the rates of syphilis are higher in moms who have other STDs or who are actively using drugs. Those are both risk factors. So I would consider drawing a test on a baby then, but really it's driven by mom's history of syphilis. Even if it's a remote history, the mom and baby should have repeat titers drawn at the time of delivery.
Dr. Sorrell, I'm going back to my original question about
Of course.
so in
Yes.
that case, if the mom is treated and her titers look good, as far as the baby, then treatment continues the same as per the algorithm?
Yep, you would draw titers on the baby to ensure that the baby's titers are low. And I would treat them just like if the mom's titers fall and stay low, but she got a medication other than penicillin, then I would treat her at that stage like she got penicillin. That makes sense.
Yes.
As long as her titers fall and remain low and baby's RPR is either negative or has low titers.
Thank you.
As long as there's not any suggestion of inadequate treatment, reinfection in mom or baby, I think you can follow the algorithm like mom received a penicillin, even if she received an alternative antibiotic.
Okay. Thank you.
I would just be very cautious and be sure that testing was adequate. So if there's any concern, if titers were not drawn, if there's any suggestion, I would err on the side of caution. But if the titers remain low in mom and baby, I don't see any reason that the baby would warrant treatment if a different antibiotic was used.
Thank you very much. I appreciate your answer.
Are there any other questions? All right, if there are no further questions, and again, if you do have questions, feel free to send them to me in either the chat or my email, and I can get them answered for you if you think of something later. But I will go ahead and post the link to the evaluation in the chat in just a couple of minutes. And again, if you need any help, please reach out.
Hey, Kelsey, I can answer real quick. If our patients are allergic to penicillin, we do penicillin desensitization.
Okay.
I can send you guys more information on that later too, if you want to type in your email address.
How long does that desensitization typically take?
Oh, Dr. Thrill, they're admitted to our unit we admit them for a little while. I honestly don't know how long it takes. Sometimes they'll have other consults during that time too and get their opinion on it, but I can ask Dr. Yeomans for more clarification on that.
Yeah, because I would that's in the literature to do it. It just gets tricky because the treatment has to be 4 weeks before delivery. And so if the syphilis is caught, say halfway into pregnancy, and then the desensitization takes some time, you may actually miss your window to treat it.
I think we do it like as soon as it's caught for that
Okay.
region. And so they'll be admitted with us like as soon as
Okay.
possible.
Okay. Yeah, that makes the most sense.
Thank you for answering that, Jesse.
Yeah, that was helpful. Thank you, everyone.
All right, everybody, have a great morning. Thanks for joining us.